Okay, now let's talk about the different mechanisms for which you could get abnormal levels of protein in the urine, or abnormal proteinuria. So remember how we said that low molecular weight protein and a little bit of albumin is going to be filtered and then reabsorbed by the proximal tubules. But what if this mechanism was not working? So what if the proximal tubules weren't working very well and they weren't able to reabsorb all of that filtered protein? So this is called tubular proteinuria, okay? So the problem is not happening at the level of the glomerulus, it's happening at the level of the tubules. So basically there's a tubulopathy or maybe interstitial disease that's preventing or impairing the ability to reclaim any kind of filtered protein, specifically the low molecular weight proteins and maybe the touch of albumin that happen to get filtered. So for tubular proteinuria, when this occurs, it's typically not a lot of abnormal proteinuria. It's probably in the range of above 150 milligrams, even maybe up to a gram or so, but it's typically less than 2 grams per day, and it's typically composed of a mix of proteins, not just albumin. It tends to be a lot of other things like the beta-2 microglobulin, free light chains, and a number of other small peptides. So this is tubular proteinuria, inability to reclaim the normal filtered protein. So the next kind of proteinuria comes from excessive production of these low molecular weight proteins. And so the main one that comes to mind is excessive production of free light chains, especially from like a plasma cell dyscrasia. And the prototypical example is multiple myeloma, which is a malignancy of plasma cells. So abnormal production of plasma cells, they're making too many free light chains. And so this is a monoclonal process producing one type of free light chain. And so because of their molecular size, these are filtered selectively at the glomerulus. So as you can see here, kappa and lambda light chains have a molecular weight of 22.5 kilodaltons. So they're going to get filtered at the glomerulus, and as they make their way through the tubule, remember we've already mentioned that the proximal tubule will reclaim filtered protein, but in the setting of, let's say, multiple myeloma and excessive production of these light chains, this amount is going to overwhelm what the proximal tubule is able to do. So, our body is, designed to handle normal concentrations of filtered free light chains, but essentially the proximal tubule is going to get overwhelmed with the amount produced in the setting of a plasma cell dyscrasia or multiple myeloma. So what happens is that excessive free light chains are going to end up in the urine and make their way through the tubule. So typically what's happening in this process, remember it's a monoclonal process, there's an abnormal clone of plasma cells producing either too much kappa or too much lambda chain, and this is actually making its way through the tubules and ending up in the urine here. And so there is a name for this, it's called overflow proteinuria, and I have to admit, as a nephrologist, we don't really, use this term too much, but I guess the name kind of makes sense in that we're sort of overflowing the tubules, and whatever's left over gets spilled into the urine. And so proteinuria occurs here because there's excess amount of low molecular weight protein, and really the thing you should be aware of is that it's excessive light chains. That's the problem. And seeing that in the urine is a clue that there's a plasma cell dyscrasia. There's probably a monoclonal light chain present in the blood as well. And so you could detect this by doing a serum protein electrophoresis with immunofixation, and that could actually identify the abnormal protein. Also measuring serum free light chains, you could identify the concentration of one of the subtypes of light chains compared to the other, and if the ratio is way out of whack, then that gives you a clue that you're right, that there is a plasma cell dyscrasia. So overflow proteinuria, excess of low molecular weight protein in the urine, and so the urinalysis may have a good amount of proteinuria, greater than 150 milligrams, probably less than a couple of grams of protein overall, but not that much albumin, right? So think about all this protein, it's light chains, it's not albumin. So if you measured urinary albumin, it may be very low. If you measured total protein, it may be pretty high. It usually doesn't get into the nephrotic range. It probably wouldn't be more than a couple of grams, but less than that for sure. Next, we're going to talk about glomerular proteinuria. So remember, the final layer of the filtration barrier is these interlocking foot processes with nice slit diaphragms in between each of them. So what if there's some disease that's affecting the podocytes? Let's say the podocytes are getting sick and they're detaching and falling off, what actually happens is that when podocytes are injured, they lose their super specialized structure and they sort of flatten out. This is called foot process effacement, and so you start losing the slit diaphragms. And essentially what happens is that the GBM actually loses its structure a little bit as well. Maybe it loses the nice organization of those anionic sites, those negative charges that will help repel large plasma proteins. And so when you have sick podocytes, you lose the slit diaphragms, and then you lose some organization of the GBM. Now albumin can pass through, and so when albumin can pass through into the urinary space, it will obviously end up in the tubes and end up in the urine. And so in this case, even though the proximal tubule may try and reclaim some of this, it's going to be overwhelmed, and so there's going to be a massive amount of protein in the urine in the form of albumin. So if you're measuring urinary protein in this patient, there would be high proteinuria, but there would also be high albuminuria. So this is glomerular proteinuria due to some disease occurring at the glomerulus affecting the podocytes. And so in terms of how much you'll see, you could see a little bit of proteinuria or albuminuria, or you could see a lot. And so this is the category that can result in nephrotic range proteinuria, which is above 3.5 grams per day. It could be much higher than this. And so if you were seeing a patient who had more than 3 or 4 grams of protein per day, it's probably a glomerular process and not the other two that we described. And just a real quick summary of what we covered. So tubular proteinuria due to tubular interstitial disease, typically low levels of proteinuria. You can see from 150 milligrams to less than 2 grams per day. Overflow proteinuria, excessive production of light chains. Again, a similar range of proteinuria as the tubular kind, but glomerular proteinuria, when it's due to glomerular disease, it's primarily albumin that's being lost in the urine. And this is the kind that could be anything essentially, but it's more specific for having nephrotic range proteinuria, which is proteinuria that's greater than 3.5 grams per day. So some patients, it could be as high as 10 grams per day. So something to review, and this will help you understand proteinuria.